So we'll be talking about behavioral issues, which was my official topic, but you can't really talk about behavior without also talking about development and cognition. All of these things run together and interact and overlap. So I think we'll review a little bit of that along the way. I am going to briefly touch on a few medications. Again, I think that could be a topic in and of itself, but I always want to say that the medicines I discuss aren't necessarily FDA approved, and the way that I discuss them are for the age or for the specific disorder we're talking about. Unfortunately, I think that's a common issue in pediatrics. So learning objectives, we'll talk about the common behavioral issues encountered by individuals with Dravet syndrome. I'd like to compare the changes in development and behavior in children versus adults with Dravet syndrome, and then talk about some of the considerations to take when we're choosing medicines and other therapies. So just starting with development. So in the first year, as most of us probably know, children with Dravet syndrome tend to have typical development prior to their seizure onset. So initial motor skills, initial language skills, initial social skills appear to be neurotypical at that time. And then in the second year, there tends to be what appears to be a neurodevelopmental regression, which I'll sort of explain in a moment, after seizure onset. The cognitive decline can appear as late as the fourth year, but it's typically in the second year. And I think what's important here is it's not a true regression, so it's not typically a true loss of skills. But when we're looking at IQ, we're looking at the level of learning for that child's age. And so if the child continues to get older, but their learning is not progressing at the same rate, the actual IQ number declines. So it's not a loss of cognitive skills, but it's a stagnation in their learning. And when you take the learning compared to their age, the number for the IQ goes down. So it's important to know it's not a regression, but it's a stagnation. Motor disorders develop during this time, tremor, coordination problems, ataxia, and then this is also when we start to see the behavior disorders. Around 5 to 6 years old, we have some neurodevelopmental stabilization. So the IQ number typically doesn't continue to drop. We just continue at the same slow rate. So there's not a makeup in the skills, there's not an increase in IQ, but there's not a further loss in IQ. Interestingly, some studies are trying to look at markers that precede the cognitive decline and the development of the behavior disorders. And so trying to look at children that could have risk factors for Dravet, what we're starting to see is a visual function impairment. This has been found in infants at risk of Dravet, so deficits with fixation and following, control of saccades, so those quick eye movements, shifting your fixation, and as I mentioned, this is an ongoing area of investigation. So what type of cognitive impairment do we see in Dravet? So it tends to be, sorry about that, usually moderate to severe. There are some cases of more mild impairment. The prevalence in studies has been reported anywhere from 67 to 100%. Interestingly, performance IQ is more affected than the verbal IQ, so the understanding of language. And again, there's been a lot written about what correlates with the cognitive impairment. And when they're looking at risk factors, there's a long list depending on what study you look at in terms of type of seizures, how early the seizures developed, the frequency of seizures. But what's interesting is when we look at other disorders with SCN1A mutations, there's also typical cognitive decline. And so I think the big picture is to rethink this idea that the epilepsy is what's causing the cognitive decline. So in other words, if for some reason the epilepsy were controlled, we wouldn't necessarily see the cognitive decline, and we're finding that that's not true, that it's an independent factor on its own outside of the seizures. And just as another mention, we also see children with sodium channel mutations that don't have epilepsy that are also developing similar psychiatric behavioral disorders and cognitive issues. So what type of cognitive deficits do we start to see? Again, as I mentioned early, we get the visual attention, the ability to attend to what's around you, working memory. One of the sort of biggest ones we'll talk about is executive functions, and this relates into the behavior issues as well. And neurologists, we love to talk about executive functions, and I think sometimes people are like, okay, well, great, but what is that exactly? So the way I always explain it to parents is I say, you know, what's an executive, what's a manager? The managers of your brain. So outside from all the sort of basic skills of language and attention, this is what's controlling everything else. This is your self-control, your self-regulation. Some people talk about it as kind of like the conductor of the orchestra that has to keep track of all the different parts, attend to all the different parts, have the social skills, have the planning, have the management. So it's really those higher order cognitive functions that we tend to see children and adults with Dravet struggling with. And of interest, what's spared is the language comprehension. So the specific cognitive functions, so at an early or a young age, as I mentioned, the visual processing, we start to see some fine motor and gross motor deficits. And then later, those higher order cognitive deficits, the executive functions that I just mentioned. Language comprehension tends to be spared, but language production can be impaired. So the development of like the full sentences, the ability to express yourself in language. So getting to the behavior disorders now, what are the types of symptoms that we see? So impairments in attention, focusing, sustained attention, hyperactivity. So we've all seen hyperactivity. We know what that looks like. Autistic traits, which I'll clarify a bit in just a moment. Aggression and oppositionality. And when we do screening for the different types of behavior disorders, we tend to see in Dravet syndrome patients more externalizing than internalizing. So what does that mean? More sort of outward behaviors and less of the inward behaviors. So less of the anxiety and depression and more of that like impulsivity, aggression, acting out, disruptive type behaviors. Increased behavior disorders tends to correlate with more impaired cognition, and that's why I sort of go through all of the cognitive deficits as well, because those two things tend to run together. Of interest, the behavior disorders seem to gradually decline from adolescent to adulthood, especially the hyperactivity. And what we sometimes see in adulthood is more slowness, perseveration, and interestingly, some hoarding and obsessiveness. There are still reports of, some aggression and some irritability. So again, this isn't sort of 100% across the board, but in general, some of the more disruptive behaviors will lessen, and we tend to see more slowness in older ages. So autism spectrum disorders. So autism and Dravet syndrome is diagnosed in 23 to 62%. It's a pretty big range there, again, depending on what study you look at. As I mentioned with behavior disorders in general, autism spectrum is much more likely with the higher level of intellectual disability, so profound intellectual disability. And then I think what's interesting, and at Child Study Center, where we do most of the autism diagnoses, we see this quite a bit, where there's this whole question of some autism traits, but they don't quite meet criteria for autism. And I think a lot of children with Dravet might fall in this category, so they have a lot of the what we call restricted and repetitive behaviors. So poor eye contact, those sort of obsessive, restricted interests. I like cars, or I like wheels, or I like Thomas the Train. The repetitive behaviors, hand flapping, repetitive habits, watching something over and over, the need for routine, difficulty expressing emotion. So again, these are what we call, and sensory issues fall into that category too. So the restricted and repetitive behaviors. But yet they can often have the intact ability to socialize, right? So almost overly familiar with strangers, and hi, how are you? And up in your face. And I'll be seeing a patient and sitting at my computer and they're coming over, what are you doing, Dr. Elibol? And I'm like, well, that doesn't really look like autism. And yet they're doing all the other sort of unusual, atypical habits. This does tend to persist into adulthood. And I just like this graph to kind of explain, because again, this comes up a lot when patients or families say, well, why doesn't my child have autism? And for the official DSM diagnosis of autism, you have to have both the social impairments and the restricted and repetitive behaviors. Sorry, I'm panting. Talking too fast, as I tend to do. I would encourage families when they have a concern about this, however, to have a child reevaluated when they're older. Sometimes what we see in young children is they have the restricted and repetitive behaviors, and the social deficits aren't enough for an autism diagnosis yet. They're friendly, they're making eye contact, they're playing. But as that child gets older, their social deficits can become more apparent in my experience. So you can imagine a teenager might make eye contact and have conversation, but if the entire conversation is about Thomas the Train, and they're perseverating about their particular topic, to me, that's not a good back and forth reciprocal social interaction. So if a kid is doing that, a very young child, that's okay. That's like a pretty good social interaction for a young child. And then as they get older, they might start to meet those social deficits because the way they interact becomes more atypical for their age. So I have seen cases when young children don't meet the diagnosis and then older children do. ADHD, so we've talked, I've mentioned the inattention, the impulsivity, the hyperactivity. These are all known deficits in Dravet. What's interesting is I couldn't find, and I've even, knowing we were coming here today, I was like, is there any new study that's going to give me this information? I still can't find it. So there's no confirmed ADHD prevalence in Dravet. There is a higher prevalence reported when you talk to parents and caregivers, but there's no really good studies using standardized ADHD instruments where we can really say, this is what it is based on these instruments. ADHD is treatable, so I think it's really important we have better assessments, that we do those assessments in our patients. And then another thing that's often mentioned in children and adults with Dravet is the hyperactivity tends to improve. So the attention and the impulsivity and the hyperactivity we see as young children, and as I mentioned before, there's more of a slowness as they get older, so the inattention can remain, but the hyperactivity gets better. What I think is interesting, again, as somebody who sees a whole range of patients, is that everybody with ADHD gets better with their hyperactivity when they get older. So, again, I think these studies were focusing just on Dravet patients and perhaps not looking at ADHD in general. I always say if there's an adult running around the room and jumping off the table, that's not ADHD anymore. So all the adults we know tend to be less hyperactive. So to me, that's sort of just a typical time course of ADHD-like symptoms in anybody. Adaptive behavior. So adaptive behavior is something we look at when we're looking at behavior in general, when we're looking at ADHD, when we're looking at autism, when we're looking at IQ. And so in order to even have a diagnosis of intellectual disability, you also have to be delayed in your adaptive behavior. And so what is that? These are your daily living skills. How do I care for myself? How do I interact with others? How do I have a job? And this includes things like just your activities of daily living, grooming, taking care of yourself, toileting, your social skills, concepts of money and time. And this tends to be a better indicator of everyday functioning than just looking at an IQ score. And in fact, as I mentioned, for a diagnosis of intellectual disability, which many, if not most of these children have, you can't just have a low IQ and cognitive score, you must also have a low score in your adaptive functioning, and that's actually how we diagnose intellectual disability. Adaptive functioning can also be decreased in ADHD and autism, independent of IQ. So if you have a high IQ, for example, but you're really suffering from autism-like symptoms or inattention and hyperactivity, you can also be impaired in your adaptive functioning. So again, in Dravet, adaptive functioning is not just cognition and not just IQ. There's many other things that can be contributing to this. This would be a talk on its own. I just wanted to throw something in there for those of us who like to think about the science of why is all of this happening. So the etiologies of the cognitive behavioral deficits are mostly theoretical at this point, but there's been 3 theories that have been sort of discussed in different ways. And I'm actually going to go to the next slide, which gives a little more detail on that. So the dorsal stream vulnerability hypothesis. So this is in the brain, we think about what's called the dorsal stream versus the ventral stream. And in medical school, we're taught, okay, well, the dorsal stream is the where is it pathway. So visual information comes in, and this tells me where I am in space, where it is in space, the where is it, and then also helps me navigate myself in space. And then the thought is that that is the impaired pathway, and the ventral pathway, which is the what is it pathway, is preserved. So that's what is the object. Tells you what the object is, and that's more language comprehension, as I mentioned, which is also more preserved. Another hypothesis is this cerebellar-like pattern. So we know in SCN1A mutations that there's decreased excitability of the Purkinje neurons. And there's a syndrome called the cerebellar cognitive affective syndrome. We all think of the cerebellum as just affecting motor skills, right? So somebody gets drunk or has had too much alcohol and they're ataxic, so that's your cerebellum, and that can give you tremors and ataxia. But we also know in people who have cerebellar deficits that you can have trouble with cognition and affect, similar to what we would see in ADHD and executive function deficits. So there's been a proposal that that could also be responsible because it would explain both the development of these motor abnormalities we see in Dravet in addition to some of the cognitive behavioral deficits. And then the third one that's been proposed is this sensory motor integration deficit. So that is, what that means is all of the sensory information we're taking in with sight, with sound, with touch, we take in all of this information and then we process it and we choose a motor output. What do I do about that? And so there's a list of symptoms there that could potentially be attributed to a sensory motor integration deficit. And the most recent review papers have, I think you can ascribe different symptoms to different ones, and there's probably a combination of etiologies involved there. So outcome, as I mentioned, behavior disorders tend to associate with cognitive decline. And I think one thing that's really important is to remember that it's not just the seizures that we need to focus on in our patients and in our children and our families. Adaptive functioning is greatly influenced by the behavior disorders, the cognitive deficits, and the motor deficits. And actually, behavior disorders are some of the strongest predictors of a decreased health-related quality of life. So what does that mean? It means we really need to have better routine screening for cognitive and behavior deficits in all Dravet patients. Now, Scott's probably up here giving me the side eye because he has been trying to work on this with the Child Study Center for a couple of years now, getting a straight line for our Dravet patients right to the developmental pediatricians. And he's right. We need to set something like that up. I think all of us know that right now there's just a dearth of behavior specialists in the country right now to help us, right? We have Dravet patients that wait for 1 to 2 years just to get in with a developmental pediatrician. So it's a really important thing we need to do, and again, we're just trying to work out a method to do that. But I think this routine screening can be done in different ways. It should start after the diagnosis and continue regularly through the preschool and the school years. Testing can be done now. I came from Massachusetts, and I learned every state is very different in how this is done. But there's private testing, both psychological or neuropsych testing. There's school-based testing. Any child with any concern like this has a legal right to free testing for this through the school system. Now, the school system can't tell you the child has ADHD. But they can do the cognitive testing, they can do the adaptive functioning testing, and they can do a behavioral intervention plan. So they can't necessarily give you that diagnosis, but they can do the testing and mention those symptoms, which will help alert you and come up with a plan to intervene in school. The school can also do autism testing and give what's called a school diagnosis of autism. In Texas, I've learned you still need a medical diagnosis to get the therapy, but again, you can do quite a bit of the school system if you just know how to navigate it. Then you have school accommodations that can be put in place. And then the other way, as we all know, to address some of these is counseling, different therapies, and medications. I'll just mention a few of those briefly. So if we are concerned about autism spectrum disorders, ABA is the only research-proven therapy to be helpful for autism. The resource that I like the best is from the Autism Speaks website. It's an amazing website. It has resources for schools and for parents and for families and for providers, and they have I can't remember how long this handout is, a 7-page handout on what is applied behavioral analysis, how do we get it, what does it do. So this is the therapy. It's behavior therapy. It helps you understand the behaviors, and again, behavior doesn't just have to be misbehavior, any behavior. Social skills, those interests, difficulties with routines. ABA helps with an increase in language and communication skills. It can actually help with the attention and the focus, and it can really work on decreasing those externalizing behaviors, right? The disruptive behavior, the aggressiveness, those types of things. And I'll just mention also that for parents who do have a child with an autism diagnosis, I'm sure I don't know if they'll appreciate me saying this, Autism Speaks has a free hotline that you can call with any questions, and they will give you any resources. There's a Spanish hotline and an English hotline. So they call that 1-800 number. I have families that live in parts of the state where I don't know all of the ABA resources or all of the autism resources, and they can call Autism Speaks, give them their zip code, and there's a person on the line that will help them navigate what's near them. So it's a really great resource to have. So let's say you have a lot of disruptive behaviors and you don't have autism. You can't get, so ABA, truth be told, would be helpful for any child with behavior issues, even without autism. I wish everyone could get it. It's the battle I'll probably be fighting until I retire, but it's very expensive, so insurance won't pay for it without an autism diagnosis. So what do you do if you don't have that diagnosis, but you know you have some problematic behaviors that we need to treat? So the other option is something called parent management training. So this addresses disruptive behaviors through behavior management techniques based on the same behavior science and the same research that we actually use in ABA, but we don't call it ABA, and it's slightly altered for the child. So this is rooted in a functional behavior assessment. This is not play therapy, and this is not talk therapy. Those are not things that are going to be helpful for this particular type of issue. It helps families understand the causes of the behavior, it gives them techniques to keep track of it, and then strategies to actually intervene on those behaviors. So I have a few resources in my slides. I hope you all have access to them in terms of, we don't have anyone in our area who does parent management training. Now in this area at Child Study Center, we've created a 5-page handout of all the providers we know that do parent management training, so I think that's something you can always look for in your area. But a lot of parents say, well, what can I start reading about? Can I do at home to help myself? So this is one good one, Parenting the Strong-Willed Child. And I would just like to say, even for a child with who has medical complexities, or even for a child with intellectual disability, these techniques can work. You can adjust these depending on the child. So this doesn't just have to be a non-medically complex, neurotypically developing child. These techniques work for anyone. So Alan Kasdan was one of my favorites. He runs the Parenting Center at Yale. He's a behavioral scientist. Again, this is not just based on, my personal experience with my child. This is rooted in research into behavioral science. This is his book. He actually has a free online video course where you can click on lectures and watch those. And there's a CD that comes with the book. I have to be perfectly honest, I haven't opened the DVD yet, but I have read the book. So I can't promise I know what's on that DVD. But this is a great one that I recommend to my parents. This is also by Alan Kasdan. This is more for providers, walking them through what is parent management training and how do you do it. And then this is one additional resource that doesn't just go through disruptive behaviors. It goes through ADHD and anxiety and disruptive behaviors, a whole list of different types of behavior disorders and how to intervene. And then just 2 slides on treatments and I'll be done. Things to think about when we're thinking about medication. So the one thing, as all epilepsy doctors will tell you, is be very careful with the sodium channel blockers. So these have been shown to actually have a negative effect on cognition down the line. So you have to be really careful with that when we're looking at cognition. The other one I would be careful with are the first generation neuroleptics, or what we used to call the typical antipsychotics. So things like haloperidol, or Pimozide. These have a very high risk of extrapyramidal symptoms, so those Parkinsonian type symptoms, the ataxia, the imbalance, and children with Dravet syndrome and adults with Dravet syndrome have a high risk of those types of symptoms anyway. Now I have to be honest, in my practice, given the complexities of the patients I see, sometimes we get to the point where we kind of have to try things anyway and just see how they do and monitor those symptoms, but this is something you should be very careful with. There's no other real definitive medication contraindications other than just being careful about interactions with your anti-epileptic drugs. And then last thing, other treatment considerations. I think as neurologists, we take a bit of an approach more about treating a symptom and less about treating a diagnosis, right? So if I see a patient and I go through that DSM checklist for ADHD and they don't have the 6 of 9 symptoms and they don't meet that psychiatric DSM diagnosis, but the parent comes in and says, I have this very functionally impairing symptom and I need to do something for it, I think, well, do I have a treatment that treats that symptom? And yes, I do. So I don't think we need to focus so much on the diagnosis as, do you have an impairing symptom and do I have something that can help with that? And I think one good example, for example, are traumatic brain injuries. We use ADHD stimulants in people recovering from traumatic brain injuries. So they don't meet criteria for ADHD, but we know they have impairing symptoms, and I have a medicine that can help with that. So I think that's a really important thing to remember. So for ADHD-like symptoms, we have the stimulants and the non-stimulants. I will say I have noticed there is a higher risk of some side effects in any child who is neuroatypical with these medicines. The side effects are not dangerous, but they tend to have a higher propensity to get moody or irritable on these medicines, so I always warn all parents, we might have to try 2 or 3 before we find one that helps you without side effects we don't like. We should try the process because I think the end goal is very important, but you just kind of have to be prepared for the ride. These are safe in epilepsy. As we all know, children with epilepsy have a higher risk of ADHD in general, and we use these in a lot of our patients. And then for the disruptive behaviors, again, I've just kind of put a list here. We have the alpha agonists, and then those second generation, those newer neuroleptics. These can also have a risk of those extrapyramidal side effects, the Parkinsonian-like symptoms, but the risk tends to be much lower than with the other ones. Oh, I lied, I do have one more slide. Sleep disorders, I think this is, and I know Dr. Pearson already talked about this, so I won't go into this in detail, but this seems to be one of the most overlooked and problematic symptoms that parents bring to me at the Child Study Center, and one of the most disruptive to the family. Children with these types of behavior disorders and with autism tend to have very disrupted sleep. And the parents come in, they say, I'm doing all the things. We're not using electronics. I've got the white noise machine. We have a routine. I put them to bed in their own bed, and they're still not sleeping. And no one will help me because they keep just saying, better sleep hygiene. Some of these children at baseline with the brain dysregulation that they have just don't sleep. And then the parents are up, the parents are not happy, they're on the verge of divorce, everybody's miserable. And I just can't say this enough because I think it's so disruptive to the family and to the patient. And so by the time they get to me, I go, I've got medicines for you and we're gonna get you sleeping. So I just think this is such an important thing for that adaptive functioning of the entire family. Anxiety and depression, again, is not as mentioned in Dravet, but it can happen, and I just want to say these medicines are safe. The one that I would be careful of is Wellbutrin because it does tend to lower the seizure threshold, so that's the only one I tend to be careful of. And just a list of references, and that's it. Thank you.
All right, thank you very much, Zelime. And I really have to thank Zelime because Zelime has been on service all week at the hospital. And just for you all that don't understand, our hospital does not have residents and fellows, and so when we're on service, we're like literally on service a lot. And she was willing to come after getting over. Usually Friday afternoon when you sign out to the doc, come on the weekend, you are hauling it as
That's
fast
why
as
I'm
you
panting.
can to get home. And she still came and talked, so I really do appreciate that, so thank you. So raise your hand if you got a question. I've got a question for you, which is that...
No.
I've got a question for you. Why won't you see my patients? Is because...
Hire more doctors for me.
Hey, I'm working on it. Is that, we know there's a high rate of hyperactivity and attention in these kids, right? And a lot of neurologists, myself included, leave the ADHD world to the pediatrician. That's... I don't do that. I treat epilepsy, and I'll let your pediatrician treat that problem. But increasingly, obviously, 2 problems happen. Number 1, they're scared to death to do it because they have Dravet syndrome. And number 2, they don't want to do it because, well, they're 4. Or, no, I got to wait till they're school age. That's when I treat ADHD. And my feeling is that we know it's a problem. We know it's a high comorbid problem for them, and it impacts them adversely for any benefits from their therapies and everything else they go to when they're not paying attention to anything that's going on anyway. So it needs to be treated.
Yes.
So would you agree? Is it,
Yes.
we need to do it? And how young is too young?
I go back to what I said before. Is it functionally impairing? If the kid's a little hyperactive, a little inattentive, but everybody's happy, the kid's happy, not causing a problem, fine. And it's the same with all those symptoms. Is it functionally impairing? And if it is, then you need to address it. And there's actually been a preschool study on ADHD medications studying stimulants down to 3 years old, and the study showed that they were safe. So we have used them down to 3 years old. Almost as with the neuroatypical children, younger children are more at risk of behavior side effects from those medicines. So they have a higher rate of getting moody and getting irritable. But it's an immediate side effect. If they have it, we stop the medicine, they're all better, no harm, no foul. None of those side effects are not dangerous, but that's again where I warn parents. Young children and children with other comorbidities sometimes have to try several before you find the thing that works. But yes, I've treated as young as 3, maybe one time at 2. But that's just between us and the camera.
Your resources are great. What do you have for adults with Dravet syndrome who have these behavior issues and sleep issues? Because that seems to be a field that needs more attention.
I agree. I don't have much because I'm a pediatrician. But the Alan Kasdan one in particular, he talks through both children and adolescents, all the way up through teenage years. And so I think some of those techniques could be helpful. And I think in these cases, we're also still talking about individuals who probably have some level of cognitive disability and intellectual disability. And I think the same techniques that we're using on children and adults on children and adolescents could be used in adults. But to your point, I mean, I can't even find studies on behavior medicines in Dravet. Like, it's a problem. They all have it, but it's just talked about, well, yes, they have a higher rate of attention, but there's no actual prevalence of ADHD, and there's nothing out there on, does this medicine tend to help behavior most, or does this? There's just nothing. So I'm approaching it the way I approach all of my medically complex children that have these issues, and using the same techniques. I wish I had a better answer for you. I'm sorry.
I have a question regarding the parent management training. My wife and I live in Atlanta, and we're just wondering where we could find a resource. Is there a website to go to that has reputable people on there? Or
I can't believe I'm saying this, but Google.
Google. What is that? How do you spell that?
There's a particular type of therapy that you can look up that's actually, and there is a website called PCIT, Parent-Child Interaction Training, and that's for a particular age range, and it's in the same family as parent management training, and there is like a national, I can't remember what it is, but there are national PCIT organizations and websites that can talk about it and give you providers in your area. If you're in a large city, there's going to be good people there. I think I struggle more with my families who live further out or in small towns where there's just not as many resources.
All right, thank you very much.
Thank you. Hey, how do you tease out the difference between your child having ADHD or bipolar or both? It gets really tricky.
It does get tricky, and I'll be perfectly honest, I'm not a psychiatrist, and so when we start to get worried about bipolar, I get them involved. I'm just not as experienced with bipolar. My understanding, I did do sort of an unofficial psychiatry fellowship. I've worked with psychiatrists. I think it's in the degree, right? And with bipolar, we're also talking about more mood instability, more mania versus just a certain level of hyperactivity. Now, I will say, to your point, I think where it gets very tricky is one of the executive functions that people forget is, right, so I think of executive functions as self-control and self-regulation. ADHD is a disorder of executive functions, right? We don't control our attention. We don't control our activity level. We all know people with ADHD who, when they're doing something they like, they focus just fine, right? They hyper-focus, and you can't make them stop. So I always say it's a terrible name. It's not even an attention deficit disorder. It's an attention regulation disorder. And one of the executive functions is the ability to regulate your emotions. So people with ADHD do tend to have this like up and down, everything is great, and now everything is terrible, and everything is great, and I'm really frustrated, and now I'm mad. It's like, it's this, right? But bipolar, I think we're talking about much more severe extremes of behavior and mood. And where that line is, I'll be honest, I just don't have enough experience with bipolar to really be able to tell you. I know it, I know the ADHD when I see it, I know the executive functions when I see it, but I haven't seen enough bipolar to answer that.
Would part of it be like getting in more fights and stuff like, I mean, just more?
Not necessarily. And again, not being a psychiatrist, there are other symptoms that go along with bipolar in terms of the dangerous behaviors, when you think of mania, and there's different, and I should also say there's different types of bipolar and different degrees of that. So again, that's just not something that I have enough experience in to be able to tell you, but for sure you can have emotional dysregulation with just ADHD. Scott, on your right.
Right next to me.
While you're here, I'm just wondering, you had mentioned other behavioral disorders that are associated with an SCN1A mutation, or there may be sodium channelopathy. Can you expound on that?
What I was referring to are similar things that we've talked about.
Okay.
ADHD, disruptive behaviors, aggression, similar things to what we've discussed.
Right, so they actually have a known mutation, the kids that are coming in with these.
Well, and we know that SCN1A mutations don't always lead to Dravet either. So it was just that the epilepsy alone and the SCN1A mutation is not enough to account for the cognition and behavior, because you can have that mutation or sodium channel problem and have no seizures and still have the behavior problems.
You had mentioned that, of course, there's no real literature out there on what behavior medicine will work best. Just in your experience, have you seen anything that you felt was particularly helpful, either for the ADHD or for the other behaviors?
So it's super individualized, right? So it depends on the patient. It depends on the particularities of their behavior. With the ADHD, the most effective medications are always going to be the stimulants. We have non-stimulants, and people like to use them, and they just, for some reason, feel more comfortable with them because there's all this press about how terrible stimulants are, and we're drugging our children. Stimulants are some of the most well-studied, safest medications that we have. I only use the non-stimulants when the stimulants, we've tried several, and we're just running into side effect after side effect after side effect, and I can't find one that works. Or I'll use a non-stimulant as an add-on. But for sure, you know, the methylphenidates and the amphetamines, all stimulants are either methylphenidate or amphetamine. There's only two categories. They work the best. And when they work, they can be life-changing. I mean, a parent will say, you have, like, we are finally happy.
Oh.
Don't be afraid to use them and try them.
Hi, thank you very much. And I just want to say I'm from Massachusetts too, so.
Where?
I live right outside of Boston. So we've seen neuropsych
Go Bruins.
through MGH and all that, and we were working to get a bunch of meds for his extreme ADHD.
Extreme ADHD, you
Yeah.
mentioned? Extreme ADHD.
But I feel like they all increased his seizure activity, like they lowered his threshold.
And this was the stimulants?
I don't recall. So,
So the question of stimulants and seizures is a long-standing question. I did a review talk on this a few years ago. Of all of the studies that I have seen on ADHD stimulants and epilepsy, there has been no definitive correlation with seizure increase. There were a few case studies in children with severe refractory seizures where they reported an increase in seizures in those few patients. The majority of the studies have shown no risk of the stimulants. And in fact, we use some stimulants to treat seizures. We use amantadine for absence and I think atonic seizures. There was one study where they actually looked, now again, it wasn't specifically Dravet. There's nothing specific in Dravet. But there was a study looking at Adderall or amphetamine and actually showed that the seizure burden decreased. So in my experience, if a child has significant ADHD-like symptoms and epilepsy, I always am willing to try a stimulant, start low, go slow, and have the parent give you feedback on how they're doing.
I'm remembering now as you're speaking, but I don't know what category they're in. So we did try Ritalin,
Methylphenidate,
and we did try guanfacine.
it's a non-stimulant.
Both of them are?
Ritalin is a stimulant and guanfacine's a non-stimulant.
Okay.
And you felt like he had more seizures?
Yes. And we also could not get everything you said resonated with me. We couldn't get the autism diagnosis because he is very social. He does make eye contact, but he is all over the place. Mm-hmm. So they did refer us for the parent training, but unfortunately insurance wouldn't cover it for us, and it was just way too much money.
Yeah. You live in Massachusetts still? Okay. Darn. Taxachusetts, they're supposed to provide everything. I would try more medicines. I mean, genuinely, I have families that have to try 2, 3, 4. Ritalin's one of the stimulants. I feel like there's more, but I can't. Okay. I just, and then there's other non-stimulant options that you could talk through. I mean, there's a lot of options.
Great. Thank you so much for this.